Oh no, I don't have to leave. I just stay where I am. Let them come to me, which I like. You don't have to get dressed to go out on this cold winter day and get an ambulance to take you there, and you're in and out of the ambulance, you're in and out of an emergency room, you're freezing, you're not with it at all. It's not nice. That's why I say, telling the boss here that I like everything in-house as much as possible, or more than possible. And it's running that way now. They're starting to come around to patients' way of thinking, I think. It takes a while, but they'll get there.
We're delighted that you're joining us today on this very exciting project. The goal is to allow seniors to stay in their own homes in long-term care rather than being transferred to acute care where they can suffer a number of complications.
From a patient point of view, a lot of the elderly patients that come into the department, and we see a lot, run the risk of being admitted and then staying in a bed in the emergency department. They may be moved from one bed to another, they may be moved from there to upstairs to another bed. We're starting to see increasing confusion, we're seeing increasing falls, we're seeing worsening situations with morbidity. So it's not particularly, even though it's a health facility, it's not a particularly healthy place for an elderly person to be if they really don't need to be there. And having an alternative treatment location takes care of them, takes care of their needs, and is obviously cost effective too. It costs less to send them back for the same treatment than it does to bring them into hospital. And when the treatment is totally the same that you would get back in the facility as it would be in hospital, it doesn't make sense to keep them in an acute care bed in a hospital.
The pathways that will be used in this study to support seniors in long-term care were developed by Dr. Mark Loeb, an international expert in infectious disease and long-term care, and also faculty at McMaster University and also at Hamilton Health Sciences.
So as Dr. Papiano indicated, we developed two clinical pathways, one for pneumonia and the other for urinary tract infections, to help manage these types of situations among residents in long-term care facilities. And the results, which were published in JAMA and BMJ, showed that use of these pathways can reduce hospitalizations, can reduce length of stay while in hospital, and can reduce inappropriate antimicrobial prescriptions.
There may be instances where the infections are severe and seniors will be transferred from long-term care to acute care. The goal is that there'll be a rapid assessment and treatment of seniors, allowing them to go back to their own homes sooner with our support through the liaison of our team and the local hospitals in this region.
Transferring to ER is never easy, especially when we can't predict how long they'll be in the ER. Sitting on a stretcher for several hours can lead to skin breakdown, which just returns them back to the home afterwards with more problems and more openings for infection and more disruption to their daily lives. Not all long-term care residents are candidates for IV treatment. The ideal candidate is someone who has a reversible illness, something that we are pretty sure we can treat and reverse. They also have to be cognitively aware not to pull on the IV lines and to allow for the full treatment to complete. If we can avoid that transfer and just start the IV antibiotics treatment right away and prevent the illness from getting worse, we save the resident and the healthcare system and the families a lot of time and disruption to their daily lives.
We're excited about this program for seniors as we believe there'll be better health outcomes and will prevent transfer to acute care where there is a risk for hospital-acquired infections for our frail seniors.
You can use these tools in your nursing home by working through two clinical scenarios. Let's look at how the algorithm for suspected respiratory tract infection would guide treatment of the resident. It's often the frontline staff, such as the PSW, who notice non-specific signs of infection. It's the responsibility of these staff to report to the nurse if the resident presents with a decline in functional status, and this is often associated with new or increasing confusion, incontinence, falling, worsening mobility, reduced food intake, or failure to cooperate with staff. The nurse will then perform a more thorough assessment to identify a suspected respiratory infection. The resident is assessed to rule out other causes of infection, such as soft skin and tissue infections or urine tract infections. It's important to assess then if there are 2 or more signs of respiratory infection, such as fever, which we define as a single oral temperature over 38 degrees, or an increase in baseline temperature of more than 1.1 degrees, a new or increased cough, new or increased sputum production, pleuritic chest pain, or new or increased abnormal findings on chest exam. These signs and symptoms of a suspected respiratory infection should then be reported to the nurse practitioner or attending physician for further assessment. The team will then assess if the resident's condition is appropriate for treatment on site in the long-term care facility. Important questions are, is the resident able to eat and drink? Is the pulse less than or equal to 100? Is the respiratory rate less than 30? Is the systolic blood pressure greater than or equal to 90? And is the oxygen saturation greater than or equal to 92? If the resident meets these criteria for treatment on site, a mobile chest X-ray is ordered, if it's available, to confirm pneumonia. It's also recommended that a CBC with differential be obtained. It's important, however, that treatment is initiated promptly. Therefore, don't delay treatment while waiting for test results. The team must first ascertain that all treatment decisions are aligned with the resident's goals of care. If treatment is appropriate, antibiotics are prescribed and administered as soon as possible, ideally within 4 to 8 hours of onset. The algorithm includes recommended oral medications for treatment of respiratory tract infection. If the patient shows signs of dehydration, for instance, oral intake is less than 1 liter per day, consider starting hypodermocolysis or intravenous fluids. If the original assessment of the resident, however, does not meet the criteria for treatment on site, or if the resident's condition worsens after treatment is started, transfer to the hospital should be coordinated. If there is a delay in transfer, consideration may be given to provide oxygen if the oxygen saturation is less than 90%. And if oximetry is not available, consider initiating oxygen at 2 liters per minute. In an effort to expedite readmission to the long-term care facility, the hospital may consider transferring the resident back to the home once the resident is stable and criteria for treatment in the long-term care facility has been met. If the resident requires intravenous antimicrobials, many of the long-term care facilities now have the capacity to provide infusion therapy. Now let's turn to management of the resident with a suspected urine tract infection. As with the respiratory infection pathway, any frontline staff observing any signs of decline should be reported to the RN. As signs and symptoms may present differently for those with and without catheters, let's first identify indicators of a suspected urine tract infection in the resident without an indwelling catheter. Does the resident have acute dysuria, that is pain upon voiding, or one of the following? A fever, new or increased urinary frequency, urgency or incontinence, or new flank or suprapubic pain or tenderness. For the resident with an indwelling catheter, first rule out any signs of another identifiable cause of infection other than a urinary tract infection. If there is none and the resident has a fever, the question becomes, are there one or more of the following signs? New flank or suprapubic pain or tenderness, rigors, or new onset delirium. If the resident has signs of a suspected urinary tract infection, obtain a urine culture. However, as evidence supports no treatment for asymptomatic bacteriuria, cultures are not obtained if the resident has no signs or symptoms of urinary tract infection. Treatment is initiated if the resident has positive cultures and is symptomatic. Again, as prompt treatment is important for resolution of the infection, there is no need to await culture results. Assess the resident to determine if they are stable enough to treat on-site in the long-term care facility. Important questions are, is the resident able to eat and drink? Is the pulse less than or equal to 100? Is the respiratory rate less than 30? Is the systolic blood pressure greater than or equal to 90? And is the oxygen saturation greater than or equal to 92? Just like the respiratory infection pathway, if the resident is to be treated on-site, ensure the treatment is aligned with the goals of care for the resident. Initiate antimicrobials as soon as possible. The pathway describes current prescription recommendations. Consider parenteral therapy if oral therapy is inappropriate. If the patient shows signs of dehydration, for instance, oral intake is less than 1 liter per day, consider initiating hypodermocolysis or intravenous fluids. If the original assessment of the resident, however, does not meet the criteria for treatment on site, or if the resident's condition worsens after treatment is started, transfer to the hospital should be coordinated. In an effort to expedite readmission to the long-term care facility, the hospital may consider transferring the resident back to the home once the resident is stable and criteria for treatment in the long-term care facility are met. We're confident that use of these algorithms in your long-term care facilities will help you manage residents with these infections.
I'm going to walk through the process on how you're going to enroll your home and your resident in the study through to the evaluation of the program. When a staff member identifies a resident with a suspected respiratory or urinary tract infection, that individual will notify the healthcare team. Often it is the nurse who's first notified, who will do a thorough general health systems assessment. The physician and/or nurse practitioner or the en-lot nurse will then be notified to do a more thorough examination. The director of care will maintain a log of residents meeting these qualifying criteria. If a resident is to be transferred from the hospital, such as the emergency department, with IV antimicrobial therapy, whether it's for UTI, respiratory tract infection, or otherwise, the hospital is to call the LTC. The LTC has a checklist available to guide this discussion, which will be made available to area hospitals. Once the LTC has confirmed that they will accept the resident, the ED staff, or occasionally the director of care, will complete the IV LTC prescription referral form and fax it to the pharmacy at the number indicated on the form. The ED staff will then stabilize and prepare the resident for transfer to the LTC home, including the administration of the first antibiotic dose in the hospital, if at all possible. It is important that that prescription referral form is filled completely to avoid delays in initiation of therapy. The pharmacy will contact the director of care to confirm acceptance of the IV prescription order. We'll review the order and discuss if the first dose has been given. The DOC will ensure that they have adequate staffing capacity at the time of transfer. The LTC staff are responsible for the administration, the monitoring, and the documentation of the resident's IV therapy. A key component of this IV program is to offer complementary nursing services to the LTCs to help support and build the capacity of the home to safely provide infusion therapy. We will discuss with the director of care if the home will be using our nursing services, which are contracted through St. Elizabeth. We offer 3 visits on week 1, 2 visits on week 2, and 1 visit weekly thereafter, if requested. Group training sessions are also available to enhance the LTC nurse's capacity to provide this therapy. There is no fee for these nursing services. We will then coordinate the initial delivery of the supplies and equipment, and there's no fee for the deliveries. The LTC is responsible for the charges for the supplies. St. Elizabeth will then confirm with the director of care the first and subsequent visit schedules. The goal of this program is for the contracted visit nurse to support the LTC nurse through teaching them how to safely administer IV therapy. The only direct care that will be provided by the visit nurses is starting peripheral IVs, the weekly PIC dressing change if indicated, and assistance with the ordering of supplies. The contracted visit nurses are also available 24/7 for tele-advice for troubleshooting. Once the IV therapy is completed, the nurse is to stop the infusion, remove the peripheral IV if present, or coordinate the removal of the PICC, which can be arranged through St. Elizabeth. The LTC is to notify OMS, who will coordinate the pickup of the supplies and notify St. Eliz of the discontinuation of their services. One of our study investigators then will gather the resident chart data. In addition to gathering data to identify qualitative study outcomes, such as the completion of therapy, the number of days on therapy, and the number of adverse events, our goal is to identify the resident and the LTC staff's experience with infusion therapy in the LTC setting. Our study investigator will work with the Director of Care to identify a small group of residents, nurses, directors of cares, physicians, and in-lots, and emergency department staff who are willing to participate in qualitative interviews with our study coordinator. As this is an integral component of our project, your participation in this phase of the project is key to the success. A study report will be made available to the study partners to share with your organizations. You and your teams will play a key role in collaboratively trying to describe the appropriateness of these clinical pathways and the overall use of infusion therapy in the long-term care setting.
We definitely need to have a segue into starting IV therapy, and that would hopefully help be an outside source, allowing for teaching, education, and supervision of the nursing staff to kind of, be accustomed to educate them on certain things that can happen when you start IV therapy, and to give them the support over a bit of time, and then hopefully the more that we do it and the nursing staff get trained, then they can do it themselves, which is yet again beneficial for the nursing staff, for the physicians, and for the healthcare system.
That for me is a plus, because I already have my staff trained here to do intravenous therapy in the home. I have the supplies, I have everything good to go. We would be very happy to start it as soon as possible.
I believe it's a time saver. I also believe it's less confusing for the resident than sending them out again into an environment where they totally know nobody.
They are regular nursing staff. They are regular environment, that is the building, the recreation therapy that they have. Even if they're not feeling well, the soul is willing to participate in some of those activities. So that's my take on the reason for having intravenous therapy in the home.
Two good examples that have recently in my past related to that situation where IV would be important. One would be IV hydration for a palliative care patient that would have been very beneficial, or another common case seen in nursing homes is cellulitis. So where the antibiotics, oral antibiotics, aren't effective, and you know that the next step is using the IV antibiotics, which would be beneficial. But you just can't start them here due to a lot of different reasons, and we'd have to send them to the hospital, get the IV started, and then we could continue that after. But the first thing is getting them to the emergency room. We used oral therapy for a good 24-48 hours, and the infection wasn't improving. We had to send them out for the IV therapy, and within 12 to 24 hours they were back on IV therapy, and we could continue it here, but if we could actually start that IV therapy in the nursing home, that would be more beneficial for nursing staff and the patient and family.
As long as it's in the house, among friends, among people that I know, if they're going to be doing anything, I just want to know the people that's doing it. I don't want strangers all around me.
I can still remember when the doctor came to visit me in my home. Why was that important? Because I was in familiar surroundings with people who knew me and knew my idiosyncrasies. That's what I feel that IV therapy in long-term care will provide for the residents of our long-term care homes. Familiar surroundings, people who know them, know their idiosyncrasies, and so it's a comfortable setting. Particularly for our residents who have dementia. The change in surroundings can be very upsetting, very stressful, very frightening.
They may be so confused that they don't even know why they're there, and they're sick, and then all of a sudden they're taken from what they know as their home to a strange place. And then it makes it twice as hard, not only for the resident, but for the person giving care, because the resident's confused, and so they're more likely to strike out, they're more likely to have more anxiety, because they're in an environment that they just don't know where they are.
The advantage of having familiar people in their same surroundings is the key point of having IV therapy in long-term care homes.
We're really excited about this study and the impact of our seniors' lives in Ontario, and we'd really like to thank you for participating in this study to ultimately improve the quality of lives of seniors living in long-term care. This program is funded by the Emergency Services Steering Committee of the Hamilton, Niagara, Haldimand, Brant Local Health Integration Network, with in-kind contributions from a number of key partners, including the Medical Pharmacies Group Limited, the Nurse-Led Outreach Team, the Family Council Network, the Jairus Centre at St. Peter's, and Hamilton Health Sciences. These partners have come together to ensure the best possible care for seniors living in long-term care homes, and that they get the best care in the best place.